Right.
Hello, thank you for being here today. So I'm Michael Fardis. I am a graduate from the master student in health informatics from Karolinska Institute, and I will present the results of my master thesis. So it was a study about the integration of patient-generated data into the multiple sclerosis quality registry of Sweden. It was done in cooperation with the Swedish Multiple Sclerosis Quality Register and under the supervision of Nabil, Zary, that was my main supervisor for the study. So I will start with the reason that led to this work. So we know that the majority of hospitals use health records or other structures like quality registers in the national level. And the main input that they get comes from patient visits and from lab exams. They are both findings that we can get only in hospital context. But we are missing a very big amount of information, and that information is the everyday life of the patients. So it's a big problem that today we don't have access to all this information, that they are the majority of the life of the patients. Patient visits can be 2 hours every month, twice a year, but we miss all the rest, all the other images. So the aim of the study is to propose a data flow model in order to bridge this gap between the everyday life of the patient and the healthcare sector. This can be done with distant patient monitoring, which has two main advantages. One is that we can have better management of the patients, and the second is that we can get information that can facilitate research. And the second is that we can get data that today are non-reachable, and they can be of interest for the management of the patients, as I said before. So these information are called patient-generated data or information. I prefer this term. And they are health-related data created and managed from the patients who are responsible to upload them, to store them, and to share them with the structures they want, the healthcare structures or doctors. And they can include the health and treatment history of the patient, biometric data like pulse or the mobility, the movement of the patient, or for example, or glucose measurements for diabetic patients. Symptoms of diseases, lifestyle choices, and the advantages that they have is that they can give the information between patient visits, as I said before. The data are generated continuously, the 24 hours, and most of them automatically. And we can get information about preventive care or chronic or elderly patient management. So there are two ways in order to capture this data. One is with the usage of wearable devices or sensors that are starting to get very popular today. And the second is by applications about data about factors that are not measurable with a device, and they get input from the patient. So the study had two main pillars. One was the technical part about the data flow model, how we can create a feasible model that will transfer the information from the patient context to the healthcare structure we want to have the information into. And the second was what kind of patient data do we want? What are the factors that are of interest for the Swedish Multiple Sclerosis Quality Register? And together with these two tracks, the study finally proposes a model that will include these data and will finally transfer them to the Swedish Multiple Sclerosis Quality Registry. The method that was followed for the study was the design science methodology. It's a solution-oriented methodology that gives a specific answer to the problem of an organization, in our case, the Multiple Sclerosis Quality Register of Sweden. It has two parts. One is the environment of the organization that has the problem, that needs a solution. And we take into account several needs, several realities that exist in the organization, the technology that is used, or everything that can be connected to the organization we want to help. And the second is what exists outside of in the wider environment, like the knowledge base, technology used, other solutions that have been given to same problems, articles, scientific or industrial. And together, by blending these two, finally the answer was to an artifact, a data flow model, about the import of the patient-generated data into the multiple sclerosis quality registry. So about the first part, about the medical part, there was a survey where 35 professionals answered. And by professionals, I mean doctors, researchers, nurses, and other professionals that are related directly with the multiple sclerosis quality registry, or they are doctors for neurologists that have multiple sclerosis patients. They were given a questionnaire with 11 factors, and they were asked to rate which would be the most important. So we can see that the first choice was that they wanted to have the possible relapses tracked for the patients, cognitive ability of them, how active they are, their mobility or their movement in general, how much they move, adherence to medication, whether they take their pills or not, fatigue levels, and other. But the 5 more important are these. So as I said before, there are 2 ways to track these factors. One is with wearable devices, and one with applications. So with wearable devices, we can track the mobility of the patient, the adherence to the medication, sleep disorders that they may have. That is something important when it comes to multiple sclerosis, that can have people can have problem with their sleep, stress measurement, and weight, and also weight management with smart scales. And what can be tracked with an application, maybe more important for the case of multiple sclerosis, is the possible relapses. It can be maybe with self-reporting of patients when they feel that they have relapse. Cognitive tests that can be done from the house of the patient without the need to reach a hospital or a healthcare structure. Fine motoric movement tests. I don't know if we have any neurologists here, but there are some tests that they can check whether the patient can do some fine motoric movements with his hands, and there are some tests for that. And also fatigue levels with some validated questionnaires that exist, or some questions that the doctor thinks that should be answered from the patient and can give an idea for his fatigue levels. About the second part of the study, there were some interviews with experts on the field of telecommunication, and also with people that are working in the quality register, in order to have an idea of how the multiple sclerosis quality registry works in a technical way. And there were 3 models proposed in order to have the flow of the patient-generated data, starting from the patient until the final database, the multiple sclerosis quality registry database that is on the bottom left of the screen. And the proposed data flow model was this one. It's not one of the 3. It was more or less a mix between several features that all the models have, and some new proposals that were made. So we're starting from the usage of the wearable devices. They capture the data, and then with the usage of Bluetooth, the data, and also some ISO standards about medical devices. This ISO actually that is mentioned here is certifies that the wearable device is a medical wearable device and not just an activity tracker or anything like this. So with the usage of ISO and Bluetooth standards, in order to transfer the data wirelessly, these information are uploaded into a tablet, a laptop, or a mobile device, a phone, a smartphone. They are stored there. In this point, if we have an application, is also getting the data from the patient. And from this point, then the data was decided that it should be the best to be uploaded into a cloud with the usage of the specific APIs that the cloud is using. In this point, I want to say that there is the authentication with Bank ID. That's a Swedish. That's only for the Swedish context, but it can be skipped. It's not essential for the model. After the data are uploaded to the cloud, they are pushed or pulled, depending on what will be decided from the organization, and they end up into the healthcare structure. These 3 databases are how the Swedish quality registry works, but It can be any database used in any other context. So we have this model that it's generalizable. It can be used also in other contexts. It doesn't use any specific innovation from the Swedish context. And, but it's not enough. There are other questions to be answered. The most important being how we will use this data. It's something really important in order to know what kind of data we want, what we will do with the data, how we will use them. So if we don't answer this question, it can be very possible that we cannot give a right model for the implementation we want to achieve. And the next two questions, in which time intervals we must get this data from the patient. It should be daily, twice a day, monthly, weekly, and it's really connected with what kind of data we want, and they can differ from condition to condition. And also the next question, when these data should be forwarded in order to have a seamless flow of data into the healthcare sector, so that there is no period with data coming from all patients in once and then a time that we don't have any data at all. So this should be answered also. And finally, whether these data should be validated from somewhere or they are sent directly into the healthcare organization without any validation, and also other questions that derive from this, like who will do that? Will be a doctor? Will be a nurse? These are the questions about the model, and here are the main findings about from the study. So what was found is that the technology exists for such implementations. The model is implementable, and it's simple and implementable in any context the way it is now. There are pilots and other solutions from companies, and also a big variety of wearable devices for several kinds of measurements. And the challenges that should be taken into account is, as I said before, why do we need the data, what we want to do with them, the legislation that is either non-existent or the implementation should comply with the existing regulations. Technical guidelines show that there is a common framework followed from everyone that wants to do an implementation like that. Bureaucratic issues when it comes to change or innovation. It can take so much time with discussions and until a decision is made. And finally, other concerns related with the cloud, whether it's secure, whether it's about the integrity of the data, and other questions that can be related with the cloud solutions. But the main findings, I think, it's these five. So the technology exists. There are, for example, Apple has HealthKit, or Microsoft has the Health Vault, and there are also in the US, for example, there are examples with Epic using Microsoft, Apple HealthKit in order to import data into their health record. The model can be used in any context, as I said before. The really important thing is to clarify why we need the data. And finally, the legal issues and the technical guidelines. I also think that the technical guidelines is something really important, because if we have like 3 different structures in the same country that want to initiate something, they should follow the same guidelines so that the data can be also shareable between different structures in the country, and even better in the European context. So I believe that also technical guidelines is something that should be taken strongly into account before going forward into an implementation of the input of patient-generated data into healthcare sector. So that was my presentation. I can hear your questions if you have any. Thank you.
Thank you, Mike. Any question?
You talked about validation of the data. What kind of validation you were talking about? In terms of formatting, in terms of the values of the data?
Validation, yeah. So what exists today in the Swedish, how the quality registry works. As we can see here, there are like 3 databases. The reason that they exist is that the patients in the first database, they can send some forms that are kind of self-assessment of their condition. So whenever a patient has a visit, these forms are validated from the doctor. The doctor can access the information of every patient, and they can decide whether some of these questionnaires are valid and they should be forwarded into the quality registry or not. So I think that something like this maybe should be done with any kind of information sent from the patient, because there may be some noise that should not be taken into account, or something that the doctor may think that it's not of value. So it's also very strongly connected with what kind of information we want. For example, if we need to have, like, for cardiac patients, if we want heart rate, there is not something to validate. You see the patterns. But if there are some cognitive tests, the doctor can validate whether this cognitive test is done like 3 times in a row, and we shouldn't take into account the 2. Or in cases like this, I think that it's really needed. But that's something to take into account after we know what kind of data we want, and if these data can be considered valid before we before we input them into our flow. So I believe that for some cases it's really important, but for some others you can just have the patterns and use them right away.
Any other question? I have one for you.
Yeah.
Yesterday we talked about ethical issue in collecting medical data, and I want to ask you if you have considered this aspect in your data flow model.
No, I didn't consider it so much because I had a more technical approach to in my study. So the main part was this data flow model. So I just wanted to see whether the implementation is feasible, and not so much about ethical aspects. I think that they are really strongly connected with the legal issue, the legal context.
That you mentioned at the end. Yeah.
So if we do not have a clear legislative context, and we don't have some laws that state that we must follow this way or that way, I don't think that we can be sure about the ethical considerations. But of course, the data should be protected. They should be everything should be taken into account before we.
Yes, from a technical point of view, you are using many technology that are risky for some reasons. I mean, the cloud or the wireless device. So
that's true.
I think that from the technical point of view, you have also to consider this.
I
the
think
security issues and.
Yeah, cloud can be a flexible solution, but I think these are questions that have to do in general with the users of digital solutions in any context. But in healthcare, for sure, it's even more important to be sure that we have a solution that respects the rights of the patients, and no information will be
Thank you.
misused.
Thank you, Mike.
Thank you. Was it? Okay, thank you.
Oh, sorry.